In today's episode, for the final episode of the season, we're going to talk all about a few various lab tests and how exercise can affect them. So let's dive in. Let's dive in first. We're going to talk about the thyroid. So the thyroid is a very common test we get. We specifically look at it, but I want to step back a little bit here and just talk about some physiology, right? So how this happens, a lot of our hormones, they kind of have what we call like an endocrine loop. So things loop back. And so things usually start up in the brain, go down into the peripheral tissues, and then circle back when they have enough. So essentially what it says, your body says, hey, I need some of this. It sends this sequence down, it makes it, and then whatever's made, feedback around to the brain says, hey, I'm good, stop making that. So it's no different here with the thyroid. What happens is we start in the hypothalamus, a portion of the brain. It releases something called TRH, and that goes to the anterior pituitary. Then from the anterior pituitary, that releases TSH, or thyroid stimulating hormone, which then works to the thyroid gland, and then it produces T3 and T4, which are the main active metabolites, the main thyroid hormones that we're working on. As I mentioned, the main ones, T3 is usually the one in terms of like most active, but T4 is the most prevalent. So just to take it back there, what I mean is you make a lot of T4, but then that gets converted to T3, and T3 is the one that kind of works onto the tissues of the body. And this conversion from T4 to T3 happens by iodinase enzymes, and that's not super important to know, but it's this feedback loop, right? Where you make this, and if your body has enough T4, then it stops it down. Whereas if it says, hey, I need more, then we go back up and we increase TSH and make more. So it's kind of, this is this feedback loop where if we don't have enough, we make more. If we have too much, then we kind of shut it down. That's typically what happens with it. And from a lab perspective, what typically happens is we will order a TSH with a reflex T4. Reflex meaning if TSH is out of the normal range, then it will look at T4. But a lot of times they just look at TSH. I do want to mention here reverse T3 specifically. I mentioned T3, but there's another one called reverse T3, which kind of goes backwards from in a step in there. And people talk about it all the time, like it is like this tried and true test. You need to have it. It's the most important thing. But like I went and looked just because I've seen so many people talk about this, like, oh, reverse T3. And there's really not a lot of data on it. Most of the data that I've seen is in like really sick patients, like in ICU type settings. It's a signal of stress, right? So that's what it is. And a lot of people say, oh, well, if you're stressed, it'll show as well. And I just don't see a lot of outpatient labs to confirm that. It's mostly like in the hospital stuff. So I'm not saying it doesn't play a role. It may play a role, but it's not based on robust data in the outpatient world that I can see. So that's just something to say. I'm just saying it, but that's what I want to mention there, because you hear it all the time that people talk confidently that T3, reverse T3 is the most important lab test you're going to get. But like, I don't know where they're getting that from. Obviously maybe they have clinical experience where they say, hey, in this setting I do, but clinical experience isn't data. And so I don't know where to go with that. I'm trying to learn more about that as well, but it was kind of shocking to me a little bit how little data there was. But when we're looking for TSH, T4, T3, all that stuff, we're looking for different pathologies, specifically problems with the thyroid. And if we have the TSH that's elevated, but T4 is normal or low, that's what we call hypothyroidism, meaning we're not getting enough. Where the T4, if TSH is elevated, right? If TSH is really high, that means we should be making out more to the thyroid. Say, hey, make more. But if the T4 is not making more and it's normal, we'd call that inappropriately normal. It should be way up if TSH is that high. And this is probably the most common autoimmune condition for the thyroid is hypothyroidism. And then conversely, on the other side of things, when TSH is very low, but T4 is elevated or normal, then that's hyperthyroidism. And usually it's from a nodule or some sort of source creating thyroid hormone. I also want to mention as well that you can have kind of what we call subclinical. So let's say we go back to the situation where your TSH is elevated, but T4 is normal. That would be what we call subclinical hypothyroidism. Same thing if for hyperthyroidism, if you have TSH that's high, but your T4 is normal, that's subclinical, meaning that we haven't gotten to the extreme range where our T4 is not correct. It's not in the right range, but the TSH is inappropriately elevated or decreased down. And so that's what we think about when we talk about kind of subclinical conditions there. And now I just want to touch on the effect of exercise with thyroid hormone. In hypothyroid patients, it actually seems to be very helpful. And those who exercise tend to have lower TSH and higher T4, which is kind of the goal, right? Usually we're looking for trying to control that. So usually in hypothyroidism, we have a higher TSH. This would bring it down, and higher T4 is saying that it's functioning there. Chronically, exercise does seem to affect men more. Clinically, like I mentioned, leads to a lower TSH and higher T3, T4. So things are just kind of, I think, more sensitive. That's kind of the way I think about it. When I see a lower TSH, higher T4, T3, that means, hey, our body's just a little more sensitive to that. And exercise tends to do that for most things. We become more insulin sensitive. And here it looks like maybe we're becoming a little more thyroid hormone sensitive. That's kind of what we're thinking about. And then for intense exercise, though, you can have a decrease in TSH and T3. You may see an elevated reverse T3, like I talked about before. And when you really, really intense, that reverse T3 can show that, hey, it's an indicator of stress. And so that's where people extrapolate that to in the real world. And so that's what we can kind of think of. You can see that though with extreme exercise. A lot of times it was like, the study I looked at there was with military recruits. So they were under an enormous amount of stress. They weren't sleeping. They were working all the time. So that's what it is. But overall, though, it seems to have some, definite benefits with long-term exercise. It does seem to that. From an acute exercise perspective, really not sure. Some lab changes can be seen, but it's hard to make signal from the noise. And, if I had to give my recommendations, it's probably best to not get your labs directly after exercising. Like, we've learned one thing from this whole season. It's probably like, hey, if you're going to get labs, don't just like exercise really intensely before getting them. It's probably not the best idea. So just something to think about there. I think overall here, they tend to trend in the right direction for chronic exercise. For acute exercise, may have some lab abnormalities, and it's just like not worth it. If you're going to get labs drawn, just like skip your morning workout or work out later. That's okay. That's kind of where it is there. Next, moving on to our creatine kinase, or CK. This is an enzyme that breaks down creatine and ATP into phosphocreatine and ADP, which can then be used by the body for energy. And so this is a huge one. It's a enzyme that creates these products for energy, right? It's what we need. And a lot of times it's found in areas that need a lot of energy, things like the muscle, heart, brain. And it basically helps create energy and will be involved with exercise and muscle use. So then when muscles are damaged, though, we can indicate, hey, like this is what we'll see. It'll kind of leak out into the blood, and that's what we're known though. So CK is typically a sign of muscle use and or damage, but I want to mention in foot stomp here, it's not always pathological. So it's very common to find elevated CK after stressful exercise, but we're not typically seen after light or moderate exercise. So if you've done vigorous exercise, this will happen. I mean, we have, and I'll kind of talk about it here, we definitely have lots and lots of papers of checking people's CK after vigorous exercise, and it's elevated. And so it's not perfect, but understanding that it's usually an indicator that, hey, the muscle's gone under some intense trauma, whether that's just training or something else happening in life. And so that's what we think about. From a normal level perspective, CK typically peaks around age 18. It can be higher in males versus female, also tends to be higher in Black patients, but not directly related to muscle mass. So it's independently elevated in Black patients. The ranges are kind of big. Females anywhere from like 30 to 145, males 50 to 170. But once again, also depends on sex and race as well, which is interesting. And then for pathology, meaning, hey, what is a problematic CK level? Usually like an arbitrary cutoff is about 1.5 times the upper limit of normal. So ULN, if you're following along on the screen, is upper limit of normal. And so that's kind of what an arbitrary cutoff was in one of the articles I was looking at. But once again, it will depend on race and sex. A lot of times, for a woman, it might be a 300 value is kind of that upper limit of normal, 1.5, whereas for a Black man, it might be up to over 1,000. And so we have to kind of know our population as well. And the real question is like, well, why do we worry about this, right? Why is this important? Why do we care about CK at all? And the reason we care is because if it's elevated for no reason, could be due to some sort of underlying, what we'll call myopathy or muscle issue, something like that. I mean, that's good to know. We want to know. If it's super high, maybe a sign of rhabdomyolysis, which is a dangerous condition where having too much breakdown of the muscle can lead to all these waste products in the blood and lead to arrhythmias or kidney damage, all those things. And we can see lots of problems there. And so CK, this is not a normal thing to check. Just throwing it out there. But some people do check it, and we will see a peak around 24 to 72 hours with a slow creep back down. But as I've mentioned before, we don't want to check things just for the sake of checking. I just want to check my CK because we don't know what that means, right? We've seen increases in CK as much as like 30 times after normal exercise. And so I just want to approach this here. The most important thing if we're checking the CK is for symptoms, right? We are not doing that. So if you are an asymptomatic person, the question is like, well, why are we ordering this test? What are we trying to do with this? If you're asymptomatic and the CK is elevated, you've pretty much bought yourself another retest. So pretty much the recommendations are to repeat the lab in 7 days and avoid exercise in between. And so for me, I'd rather just not know if my CK is a little bit elevated, but I'm asymptomatic, because if I find it, then shoot, well, I can't work out for 7 days, and like that stinks. So, but repeat it 1 week. If it's still above that 1.5 upper limit normal, then we start looking for other things. Like, could there be muscle disorders, endocrine disorders, hormone disorders, connective tissue issues, lots of things we look at there. And then kind of decide to go where from there. You might be like, okay, you have high CK and nothing else is wrong, but it leads to all this workup and all this worry. And so was it really worth it? However, now, if the patient is symptomatic, that changes everything, right? So if you have severe symptoms like severe pain, stiffness, weakness, like not the classic, like, oh, I'm a little sore after working out. It's like, I can't lift my arms. It's really bad. The classic example of this is someone does Murph for CrossFit and has never done it before. And then the next day their arms are puffy, swollen, can't walk, can't do anything because they did 100 pull-ups. And that's what we are concerned for rhabdomyolysis. So If it's really, really severe, that's what we care about. Or if it's just like normal DOMs, we're like, whatever. I'm not too worried about it. So, but rhabdo, usually the diagnosis for that is 5 times the upper limit of normal. And so it's kind of a thing there. And we care about rhabdo because once again, it is serious business. It can be very serious, can be damaging to the kidneys, can cause arrhythmias, can do lots and lots of different things. So we care about rhabdo, and it's not a joke or a badge of pride, but hey, I got rhabdo. We take it very seriously. And in fact, in the military, it is a very big deal because obviously, we don't want people having these issues, but also it leads to, if you have it once, you can have it again, a higher chance of that. So that being said, CK, don't check it. That'd be like my big advice. Like, don't check it unless you have a reason to, unless you are in a medical field and concerned for someone who has like rhabdo or some sort of myopathy. Like, there's really not a reason to order CK because it could be elevated and that could just be your normal baseline. You don't know. After working out, it'll be elevated. Who knows? Like, for me, unless we have symptoms, ordering a CK is one that I would not use it as a screening test. We'll put it that way. And then next, I'm just going to touch on testosterone super quickly because I have a whole episode all about testosterone exercise. The long story short is exercise does acutely increase testosterone, but usually transient and returns back to baseline about an hour-ish, I would say. And so just from this lab perspective and this podcast, once again, if you're going to get your labs, just don't work out before getting them. Like, if you're going to get your testosterone checked, don't work out really early in the morning and then go get your 7 a.m. check. Like, don't do that. That's the pretty much simple. Long-term testosterone, does it increase with exercise? That's a whole podcast I talked about previously. But testosterone, once again, is something you can see that is abnormal if you have acute exercise right before it. Next, I want to talk about our liver enzymes. And so specifically, we have a couple of liver enzymes I'm going to talk about. The AST and the ALT, these are the main enzymes used to detect liver damage. The AST helps the body break down. It's an enzyme that helps break down amino acids, where the ALT helps convert protein into energy for the liver. These are found predominantly in liver, but are also found in muscle tissue as well. So that's super important to know. Normal ranges depend on where your labs are. And as I've said a million times, your lab normals are going to be varied based on where you are. But ALT, about anywhere from 7 to 55, and AST, 8 to 48. And you will see potentially an elevation in these with exercise. You may see an increase with vigorous exercise, specifically resistance training or tasks they talk about like physical labor are most common, but they did notice it with aerobic work as well, people on distance runs. So it can be elevated for a while. And these can remain elevated for like a week. And so it can be pretty significant. And so what we'll say is generally we'll say, okay, if you're, about 1 or 2 times the upper limit of normal, that could be exercise wise. That's what we generally think of where it is. But I've seen some studies here that AST is in like the hundreds. So, I don't know what to make of that. But if someone says, hey, like I was really, really, working out hard and it's really high, then you got to figure out, okay, shoot, do I need to trend this down? Are there other things going on? That's why, once again, just checking LFTs for the sake of checking LFTs may not be the best thing, but there are other more specific markers to look at liver damage. And so I'm not going to say, hey, if your physician were to order these labs and they're elevated and you're worried, then you get other things. You get bilirubin, you get a GGT, you get alk phos, all these other labs you get to look at the liver. You look at your clotting factors, synthetic function, all these things you would do. So like, I'm not saying these are the only things, but once again, these are very common things because a lot of times these are included in something called a comprehensive metabolic panel. So we talked about the basic one before, BMP. The CMP includes the AST and ALT. And a lot of times people just get them for their yearly labs and all of a sudden it's elevated and you're like, well, shoot, what does that mean? And if you're an exerciser and you're really healthy, it can mean that we were just exercising. As I saw here, it can be elevated for a week. So we want to give it a little bit of time, not necessarily saying, hey, we understand that. I wouldn't say this when you have to hold off on exercising from a week. I wouldn't say that necessarily. But if we're elevated, then that's something we can do. Hold off on, come back over time. Because otherwise, when you see this as a physician, what happens is, okay, it's elevated. The most common thing I see, there are 2 main things. Really, the biggest one today is metabolic associated like fatty liver disease. They're kind of changing the name to it there, but essentially we're having liver damage due to metabolic syndrome. And the other one is alcohol use. So those are like the 2 main ones, but mostly metabolic syndrome is the one we're seeing with. So if you have elevated AST/ALT, I think, okay, is this person have fatty liver disease? Essentially, that's what you're worried about. And that's why you want to take it off the table and reset things. If you have an elevated one, go there and, wait a couple of days and kind of go from there. But that's kind of like my general one for liver enzymes. We can see those as well. And over here, I'm just going to say, my takeaway, this is kind of like the 10,000 foot view of everything. Lots of labs can be affected by acute exercise. It's probably a good idea at minimum to not exercise the morning of your labs. That's like bare minimum. If you really, really want to be good, then maybe a couple days, I would say. If you're worried about CK or liver enzymes, then maybe you have to wait 3 to 7 days after exercising. But once again, the most important thing is that labs in isolation mean almost nothing, right? So if you just order labs and get them, What does that mean? They have to be interpreted in the right clinical context. And that's my big takeaway here with labs becoming ever more accessible to patients. I think that's great. I have no problem with that, but you need to work with someone about this, right? Because if you just randomly check your CK or check your AST, ALT, and it's elevated, then you're like, well, what do I do with this? So I Google it and I have liver disease, and that might not be the case. And so that's the biggest take home here is that, hey, if you're going to order these, be judicious, do them based off of symptoms. And if you're just going to do them for screening purposes, then have someone you trust who can interpret these and not just worry about the internet or some Reddit forum. Because I see it all the time. People just blast up labs and say, hey, like, what does this mean? And it's really challenging. And if you've taken anything away from this entire series, it's that labs are much more tricky than we think. They're not necessarily as accurate as we think they are, which is kind of challenging the status quo. Most people think, hey, I need to know all the answers, and labs will tell me that. That may not be the case. And so once again, less is usually more in the world of medicine. And today it seems like more is more, but it doesn't necessarily, I don't think it necessarily bears out that getting more tests is necessarily better. But if you're going to do that, I want you to be aware of lab abnormalities you could find. And so I hope this was really helpful for you, but that is going to conclude this episode. But thanks for stopping by. I really appreciate it. If you did find this helpful, it'd mean the world if you either gave a 5-star review on your podcast platform of choice, or if you shared it with a friend who you think might enjoy it. And that's really it for today and this season. I hope this was helpful for you, but now get off your phone, go be active, and have a great rest of your day. We'll see you next time.